Hello, it is Ryan, and I was on a flight the other day playing one of my favorite social spin slot games on ChumbaCasino.com. I looked over at the person sitting next to me, and you know what they were doing? They were also playing Chumba Casino. Coincidence? I think not. Everybody's loving having fun with it. Chumba Casino is home to hundreds of casino-style games that you can play for free anytime, anywhere, even at 30,000 feet. So sign up now at ChumbaCasino.com to claim your free welcome bonus. That's ChumbaCasino.com and live the Chumba life.
No purchase necessary. VGW. Void where prohibited by law. See terms and conditions. 18+.
Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go get your free PDF, reallifepharmacology.com. I give a rundown of the top 200 drugs and some of the most important things that you're going to see in clinical practice, as well as things that are going to show up on pharmacology and board exams as well. So again, simply an email. We'll get you that at reallifepharmacology.com. Go get that free 31-page PDF. All right, so let's get into the drug of the day today, and that is Gemfibrozil. Brand name of this medication is Lopid. It is an anti-cholesterol type medication. Also, probably the most common I hear in practice, it's a fibrate type medication used in hypercholesterolemia. From a mechanism of action standpoint, I'll be honest, I had to go and look this up, and of course, I was justified in my knowledge of not knowing what this is, in that the mechanism of action is not well understood. And I've never, ever recall in an exam being asked what the mechanism of action is for Gemfibrozil. It's because there's a bunch of theories on how it works, and it has associations with potentially very low density lipoprotein, so VLDL, and different mechanisms that way, potentially. But again, it's all theories as to how the drug works. It's really not well understood. So that explained potentially my knowledge gap there, and not knowing what the mechanism of action for Gemfibrozil is. Anyway, in clinical practice, where I see this medication used most often is elevated triglycerides. So patients with very significantly elevated triglycerides, usually in the ballpark of 500 or higher, up to 800 to 1,000 plus, these patients are at potentially higher risk for pancreatitis. So with that, that's the situation that you're probably most likely to see Gemfibrozil used in. Now, there's some other fibrate derivatives as well, and I'll mention those in the drug interactions section as to why Gemfibrozil isn't used. So most often when I see patients on Gemfibrozil, they've probably been on it for a really, really long time, okay? So that is something that I look at and that I consider possibly in geriatric patients where we're trying to reduce meds. That is a drug that I definitely look at and say, hey, why are they on this? When was it started? And try to get a little bit more background info, because maybe it's a potential target where we can eliminate a medication there. So again, focus on those triglycerides with Gemfibrozil. That's usually where it's going to be used, versus our statin medications, which are typically going to lead us down the road of focusing on LDL, for example. Downside to Gemfibrozil, twice daily dosing. That's definitely a downside, and there are some drug interactions as well that I'll definitely discuss coming up here in a little bit. Adverse effect profile. If you go and look at it, you're going to see a list of a ton of different stuff, and there's a lot of rare things that have been reported. For your purposes and memorizing things, GI upset is the most common complaint if patients are going to have an adverse effect. I think it's in the ballpark of 20% or something like that, but that is the most common one for sure, GI upset. Rare issues, hepatic issues, rhabdomyolysis risk, skin reaction. So kind of a similar vein of some of the statins, with hepatic issues being rare, rhabdomyolysis being a rare potential complication. So that's kind of what I lump it in with as far as trying to remember the adverse effect profile, and then obviously with the most common being that GI upset that can happen. So interestingly, administration is recommended to be before meals. So usually when a med can cause a little GI upset, usually we try to dose it with meals. But it is recommended 30 minutes before meals, morning and evening, obviously. It probably makes the most sense if you're doing twice daily dosing. And the reason for that is absorption. So absorption is reduced with food. So that's the reasoning behind it. Have I seen it dosed with meals before? I likely have, but the downside to that is you're probably going to get less efficacy and less benefit from the medication there. Renal function, you can keep an eye out for that. Dose reductions of kind of 50 to 75% are typically recommended, a reduced dose to 75% of the current dose is what's recommended. So I think the important point is the cutoff that I remember anyway, if you have a patient on this, is less than 50 mils per minute. And then usually I have to go look it up because, like I said, Gemfibrozil isn't used crazy often anymore, at least in my experience and in my practice there. Onset, this is an important patient education point. We usually check cholesterol every 3 to 6 months when we make changes and do things, because that process and cholesterol lowering effect generally does take a little while, and we want to make sure patients are at a steady state and that drug has had time to work, and we want to see the results after a period of time. So that's usually patient education, and you want to set those expectations with the patients that we're going to check cholesterol every 3 to 6 months as we're maybe starting this medication, for example there. All right, so let's take a quick break from our sponsor, and we will wrap up with drug interactions. If you're in the market for pharmacist board certification study material like BCPS, BCMTMS, ambulatory care, geriatrics, psychiatry, and if you're a student looking at NAPLEX content, definitely go check us out, meded101.com/store. We've got links to all of our content there, all of our study materials. If you're a nurse, a med student, physician, another healthcare professional, I've got lots of different books. One recently on polypharmacy. I've got some on drug interactions. Lots of different resources that involve case studies and different things as well. So, again, support the sponsor, meded101.com/store, and all your purchases through those links help do that. So I'm greatly appreciative to those of you who have purchased something and supported this podcast. In addition, if you like Audible listening, which you're listening to this podcast now, I've got books on Audible as well, and you'll find those links at meded101.com/store. And if you've never done Audible, you can actually get your first book for free. So go take advantage of that. You can get a 6-8 hour book of mine absolutely for free, simply for trying Audible. And if you don't like Audible, not going to use it, go ahead and cancel. They won't charge you. But if you do, obviously, you can keep doing it. I absolutely love listening to books and podcasts and things all the time with my busy schedule there. So definitely go check that out as well. meded101.com/store. All right, wrapping up with drug interactions. So I mentioned the dosing. I want to go back to that, why Gemfibrozil isn't used as much. So the dosing, that's one big reason. Twice a day versus some other fibrate medications are once a day. And then there's potential risk for a few more drug interactions with Gemfibrozil compared to fenofibrate type products. So with that, drug interactions, Gemfibrozil does inhibit CYP2C8. Now, that's not a crazy common enzyme. It's not like 3A4, for example. But there are some drugs that may have their concentrations increase. So a couple examples I wanted to throw out. Amiodarone concentrations can go up if Gemfibrozil is added on. That's obviously a pretty sensitive medication that we're using for arrhythmias and things like that. Pioglidazone's another example. Not used very often anymore with diabetes, but its concentrations could go up there. And then the question always comes up with statins and Gemfibrozil, and it is recommended to avoid using these together, Gemfibrozil and statins, and the reason is there's an increased risk for rhabdomyolysis. Interestingly, so simvastatin, atorvastatin, it's recommended to absolutely avoid. Rosuvastatin actually does have language where it recommends up to a max of 10 milligrams if concomitant use is absolutely necessary. So if you remember rosuvastatin, typically the high dose range is 20 to 40 milligrams. They say to max out that dosing if Gemfibrozil is added at 10. And there again, we're going to obviously monitor for that increased risk of rhabdomyolysis and muscle soreness, that type of thing. But definitely important to remember that interaction with statins and Gemfibrozil. Ezetimibe actually falls under that category as well, recommended to avoid use with Gemfibrozil. Ezetimibe is another cholesterol-type medication, and I believe I did a podcast on that medication as well as the statins, of course. Other drugs that may be impacted, so it can increase the concentrations of Montelukast, so that'd be Singular, the brand name there. Also potentially can increase the risk for hypoglycemia, particularly when patients are taking agents that cause hypoglycemia, and the most notorious drug class there is going to be sulfonylureas. So maybe keep a little closer tabs on your diabetes patients if Gemfibrozil is started there. And lastly, I can't leave out warfarin. Gemfibrozil does have the potential to raise warfarin concentrations, so the dose of warfarin may need to be reduced. And we're typically going to monitor and manage that by monitoring and following the INR. So those are I think those are some of the big and most important drug interactions that you should know. With Gemfibrozil, obviously, it's not an all-inclusive list that I went through, but I wanted to pull out some of the things that you actually might see in clinical practice there. That's going to wrap up the podcast for today. If you enjoyed this episode, leave a rating, review on iTunes or Spotify or wherever you're listening. I'm greatly appreciative to those of you who have written some kind notes as well as given us 4 or 5 stars for sure. So definitely appreciate that. If you got any comments, suggestions, mededucation101@gmail.com. Otherwise, you can track me down on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Go sign up, subscribe, reallifepharmacology.com. Get your free 31-page PDF, the top 200 drugs. That's a no-brainer, I think, for you. Also, check out the blog at meded101.com. We've got articles going up there on a weekly basis, bi-weekly basis even. Different things that we talk about is things that I see in clinical practice and common questions that you may come across, as well as doing case studies and doing different things like that on the blog. So definitely a cool little resource, one that I've been putting my heart and soul into for about 7-8 years. So go check that out as well. If you like that, go ahead and subscribe at meded101.com as well. So with that, I'm going to sign off. I thank you so much for listening and for your support, and I hope you have a great rest of your day.
With the Lucky Land Slots, you can get lucky just about anywhere.
This is your captain speaking. We've got clear runway and the weather's fine, but we're just going to circle up here a while and get lucky. No, nothing like that. It's just these cash prizes add up quick. So I suggest you sit back, keep your tray table upright, and start getting lucky.
Play for free at LuckyLandSlots.com. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18 plus terms and conditions apply. See website for details.